one of the online sessions linked to the ASCAT, so the annual conference on sickle and thalassemia. Today we are going to talk about a topic that has been selected by participant of the previously edition that was in January this year. So we are talking about embryonal selection, prenatal diagnosis, and preimplantation. So with us, we have, as usually, a duo of patients and an expert physician. So Anne from Brussels and Eda from Netherlands. So Eda, I mean, feel free to take the floor and express your ideas on this topic. I don't know if you had experience on this topic or if you have any curiosity you want to share first. So then Anna would explain from a physician point of view this topic that is really important. Thank you, Eda.
Okay, there's actually just one thing I want to share, and that's, I don't know if it's only this topic, or maybe I'm talking about more than only this topic. Sorry, excuse me if it's more than I have to say, but I think that the condition that we have is really a bad condition, and for us, if we want children, it's actually, yeah, it's a really good and beautiful thing to have children. And for my condition for having children was that my ex-partner would get himself fully tested if he has sickle cell anemia or something similar. And this, of course, to prevent more sickle cell patients. I always say I wouldn't wish sickle cell upon my worst enemy, so let alone my children. So I consider it a well-considered decision to get your partner tested, if only to prevent other children having to suffer through this disease. So I'm not sure if it's going about this. So this is actually my opinion, and that's what I think about it. Yeah, that's what I actually wanted to say. Is there anything else? Questions or maybe other thoughts?
Okay, I think well, I see no reactions. I think it's fine. Thank you.
Yes, thank you.
Thank you, Eda.
Again, excuse me. I'm so sorry this is going like this, but I have to go. And I wish you a real good, what is it? Webinar? Yeah, webinar. So,
thank you very much.
Good evening.
Have a nice afternoon. Thank you.
You too.
Bye-bye.
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 Well, in the meanwhile, I just managed to transfer my file, so maybe it will be more convenient if you just open it.
Yes, I'm opening it. Just a time of. Okay, and
well, actually, I can already start maybe and present myself, and maybe also just say a little bit about the topic. So my name is Anne Delpar, and I'm a gynecologist, and I'm working in Erasmus Hospital in Brussels. And actually, I'm a specialist in infertility and assisted reproductive techniques. And so the idea is to talk here about the reproductive options for couples who wish to have a baby in the sickle cell condition. Well, the most common situation is when both partners are carriers, and as it is an autosomal recessive disorder, so there is a 1 in 4 chances that a child would be homozygous and sick. And so, well, the main reproductive options which I would like to discuss with you today are either a prenatal diagnosis, and this is performed while the pregnancy is already ongoing, or pre-implantation genetic testing, which is so I will close this. I just close my book. A very early form of prenatal diagnosis, but which implies to undergo a cycle of in vitro fertilization. So, well, I have no disclosure in relationship with this topic, and so we can go on to the first slide, the next one. Thank you. And so after listening to the webinar, I hope that you will be able to understand the purpose and the benefit of prenatal diagnosis, for whom and how prenatal diagnosis is offered, the purpose and benefit of pre-implantation genetic testing, and for whom and how pre-implantation genetic testing is offered, and the risk and the benefits of either PGT and or PND. Next one. So prenatal diagnosis, as I told you, aims at determining the genetic status of the fetus during an ongoing pregnancy. So the pregnancy is ongoing and it's offered to couple if at risk, of course, to transmit the disease within the frame of genetic and fetal medicine counseling. So it really requires a close collaboration between the genetic team and the fetal medicine team. So it is a genetic test on fetal cells, and there are two options, both requiring an invasive procedure, either chorionic villus sampling or amniocentesis. Next one. So chorionic villus sampling is a test in which a small amount of trophoblast, which will be the future placenta, is removed for genetic testing. And you can see on this slide that, well, it is performed in this specific case transabdominally. In our unit here, they do it mainly transvaginally. Next slide. So, no, just before. Yes, so where you can go here through the vagina into the cervix and collect a small amount of placenta. And in some cases where the access is difficult, we can also do it under ultrasound guidance transabdominally. So anyhow, it's possible from 10 weeks until 13 weeks of pregnancy, and we are talking about amenorrhea weeks, so which mean, well, 8 to 9 weeks after the conception until 11 weeks of conception. So there are two options, transcervically or transabdominally. Some teams would do it more through the transabdominal procedure. Puncture, yes. It's a very safe procedure, and the risk of miscarriage is very low. It's less than 1% and even less than 0.5%. So there is a short sick leave for your work, 1 to 3 days, and that would depend on the type of your work. And we can hope getting the results within around a week. Next slide. And amniocentesis is performed later in the pregnancy. So it's a prenatal diagnostic test in which a small amount of amniotic fluid, which is the fluid around the fetus, is removed. And this is performed transabdominally under ultrasound guidance. Next one. And it's possible as of 16 weeks until the end of pregnancy. It's a very safe procedure as well, with a even lower risk of miscarriage, and with a very, very short sick leave and the results within a week. Next one. So, well, clearly there is an option which emerged at the end of the 20th century with the first pregnancy obtained in 1990 with the delivery in 1991 and publication of the delivery in 1992. So, and it is a pre-implantation genetic testing, and this means a genetic diagnosis of an embryo which has been obtained by IVF, in vitro fertilization. And the principle is to select the embryo, the unaffected embryo, and these can be either carriers or unaffected, and to discard the affected embryo, homozygous for the condition. So it's sort of a very early form of prenatal diagnosis, and within frame of genetic and IVF counseling. Next one, please. So there are, of course, many indications for the PGT, and I will not go into the details for this, but regarding sickle cell disease, it's what we call PGTM, pre-implantation genetic testing for monogenic disease. And you will hear also about PGT-SR and PGT-A for chromosomal aberrations, and we can also test some mitochondrial diseases, which are much rarer. And we can also, in some cases, have requests in very specific conditions for HLA typing, which means that this can help couples who in certain conditions, if they already have a sickle child, they can have a child which is of course not affected by the disease, and in addition would be compatible for
bone marrow transplantation.
in need of a stem cell transplantation for the affected child. But this is very, very specific and very rare request as well. So next slide. So for monogenic disease and of course sickle cell disease, the main condition will be two future parents who are carriers, but we also can address situations where there is a patient who is homozygous and the partner heterozygous, and in this case, of course, there is 50% chances to have an affected child. Next slide. So, for whom is it specifically addressed? For couples who are infertile and who anyway have to undergo in vitro fertilization, but we propose it now to all couples as an alternative to prenatal diagnosis, and the main difference being that there is no need to terminate a pregnancy if you go to PGT, while this would be the case in prenatal diagnosis. Of course, couples who have already undergone previous history of termination of pregnancy and prenatal diagnosis are really, well, they are willing to go rather to a pre-implantation genetic testing to avoid a second termination of pregnancy. Next one. There are some restrictions to the PGT. well, not a lot for sickle cell disease, but it's a quite common request. So we do not have a lot of technical problems related to specific pathology, but regarding from where you are in Europe, there can be some legal restrictions to PGT. I'm talking about ethical restrictions, but these are mainly for other pathologies because sickle cell disease is considered as an acceptable request in all teams performing preimplantation genetic testing. And biological restrictions of the PGT also do not concern patients with sickle cell disease, but rather some pathologies where the genetic diagnosis is not clear, for instance. Next slide. So, of course, it's very important that if we want to propose to couples PGT, it has to be integrated in an appropriate environment. And the teams who perform PGT, as I told you before, have a very close collaboration between the genetic team, the ART laboratory, and the reproductive fertility specialist. Of course, the couples should be fully aware of the advantages and the limitations of the preimplantation genetic testing, and also have the information about prenatal diagnosis, and especially if they have no problems of infertility. So we will go into the details of the pre-treatment assessment. Of course, we have to see if it's feasible technically. We have to counsel the couples, where the couples have to sign the informed consent. And then there is some delay to validate the test technically on the genetic side. And well, it's rather rapid for sickle cell disease. It can be a few weeks. And then, of course, check that there are no contraindication to ovarian stimulation, and have a checkup for the medical file of the assisted reproductive technique. And then there is a treatment which is very similar to an IVF treatment, and all the steps of the ART laboratory with the embryo biopsy. And then the embryos are frozen during the time of the genetic analysis, and they are thought for a transfer of an affected embryo. Next slide. So in reproductive medicine, the couple will have a pre-IVF examination and test, PGT counseling. They will sign the informed consent about the procedures, and alternatives will be discussed. And in genetics, of course, the diagnosis has to be valid and known. Then there is a pedigree which means all persons who are affected in the family, but usually it's rather straightforward for sickle cell disease. And then, of course, there is also explanation about the procedure, signature of informed consent. In some cases, sampling of the family, and of course, sampling of the probants. Both partners have to be sampled. Next slide. Okay, error. Yes. So for the IVF treatment, well, the first thing is that if we want to be efficient, we need to have as much as possible embryos. And of course, there are a lot of steps, and well, before getting to an embryo. So if we go in a natural cycle, there is only one follicle, which is the structure within the ovary containing the oocyte going to maturation. And of course, then if we do not stimulate the ovary, we will just, there is a lot of possibility that we cannot get the oocyte and we cannot get the embryo. So the first step is an ovarian stimulation, and the aim is to get as much as possible oocytes. This ovarian stimulation will last about 2 weeks, a bit less, well, let's say 10 days. And this is an ultrasound that you can see, where you see those large black round circles, and these are the follicles, mature follicles, and they are black because they contain follicular fluid, and the fluid is liquid, and so it's hypoechogenic, so we can see it very well. We do not see, of course, the oocyte on the screen because it's tenths of a millimeter, so it's very, very small. We just see it on the microscope. But we will then trigger the ovulation when we are at the end of the stimulation. We just induce ovulation, and then we will perform the oocyte retrieval 36 hours later. So we have to be very, it has to be done between 35 and 37 hours, and this has to be respected to get the oocyte mature. And this is performed transvaginally. We can do it under local anesthesia, but we do it usually under a very light general anesthesia deconnection. We talk with the patient still, but they sleep a little bit. So you see the vaginal ultrasound probe, which is connected to a needle, and we have the screen where we can see the follicles, and so we will pick and aspirate the liquid, and then we can go on the next slide. On the lab, yes, they will collect those liquids and isolate the oocyte. And you can see here an oocyte on a very big microscope, which you can see on the right side. And this is a tenth of a millimeter, so it's very, very small. And so we will micromanipulate these gametes. So of course, the partner has to provide a sample of semen on the same day. And so on the left side, you have a pipette which will maintain the oocyte, gently aspirate the oocyte to maintain it. And with the other one, we will just go and inject a sperm cell into each oocyte. So this is what we call ICSI, intracytoplasmic sperm injection. So we just inject a sperm cell into each oocyte. Next slide, please. And then we will firstly look at the number of oocytes which have been fertilized. And you can see that on the left side that you have 2 pronuclei. So this is the first step of the embryo, the zygote. And then we will follow, if the oocyte has been fertilized, we will follow the embryo in culture until the development on day 5 or day 6 of a blastocyst. And you can see that there is a major difference between the appearance of an embryo on day 3, and it has 8 cells usually at that time, but you can see that all cells are the same. And then between day 3 and day 5, the embryo starts the differentiation, and you will have what we call the trophectoderm, which is in periphery and which will be the future trophoblast and the future placenta. And then there is the, how do I say that now in English? Bouton embryonnaire, the small amount of cells which will be the future embryo. And at that stage, we will biopsy a few cells from the trophectoderm, so in the periphery of the embryo, and then we will freeze the embryo, and this is a vitrification. It's very rapid freezing, and the embryo will be kept frozen until we get the genetic analysis. And then the next slide, please. And well, everything looks very nice when you think of it, but you have to know that, of course, the fertilization rate is not that high. Well, here I show an example of 10 oocytes retrieved with 8 embryos obtained, but usually it's rather, well, 70% or even 65%. And then well, the embryos fertilized, which will evolve until the blastocyst stage, well, the rate is about 50%. And then, of course, you also have to discard the embryos which will either be affected or where the genetic diagnosis was not performed because, well, amplification, for technical reasons, sometimes it cannot be interpreted. So, well, there are some situations where you end up without any embryo available for transfer, and even if you have an embryo available for transfer, all will not implant. So it's sometimes a long story. Well, this is the pessimistic view, but you can also have the optimistic one. And of course, they have more than one embryo unaffected and be pregnant at the first cycle. And then you have 2 additional embryos frozen that you can keep for years and come back to have your second or third child. So we discard affected embryo, which are homozygous for hemoglobin S, and we keep the embryo either carrier, so healthy heterozygous, or homozygous normal. Next, please. So why can it fail? Well, some patients have a very low ovarian reserve, meaning that they cannot answer properly to the ovarian stimulation. We cannot stimulate them. We cannot obtain the oocyte, or there is only one follicle and no oocyte found in it. Sometimes we have no sperm. I mean, we of course check it before, but sometimes, well, the partner cannot give a sample on the day, or it was okay, and then in some rare cases it is azoospermic on the day of the oocyte retrieval. We can also have a fertilization failure. We get the oocyte, we get the sperm, we put them together, but there are no embryos. And we can also have no blastocyst development. So we have embryos, but they will just be blocked after 3 days, no good until to the blastocyst stage. And also in some situation, the quality of the embryo, we cannot have, it's of too low quality to be biopsied. And some technical issues related to the genetic testing as well, or in some conditions, the patients are spontaneously pregnant. So, of course, the PGT can be performed in infertile patients, but also in fertile patients. Next one. So, when we get the results, then we see the couples. There is they explain them if they have an affected embryo, and then we can prepare the embryo replacement. And this is very simple because we can do it with a hormonal treatment or within a natural cycle. We just check for the ovulation, and then we just will count for 5 days after the ovulation, because just to synchronize the endometrium, which is the inside the uterus, and the embryo, just to offer the highest chances of pregnancy. And so this is in a consultation under ultrasound guidance, and we just put very gently a drop, a very small drop with the embryo that we cannot see. So it's a very, very small drop. And then the laboratory, they will check the catheter to be sure that the embryo didn't stick to the end of the catheter. Next slide. And what is very important to know, that's one of the major complications of those treatments is related to multiple pregnancies. And so I think that if all this procedure is performed, I think that we have to really counsel the patients and explain them that there is a high risk in having twins for obstetrical complications and risk of premature delivery. And it's completely related to the number of embryo replacement that we replace, and so we can prevent it easily by performing a single embryo transfer, which we really recommend in our team. But it's a long way. You can see that, well, in Europe, you can see that the single embryo transfer is increasing regularly since the last 20 years. And on the other hand, well, the rate of twins is decreasing, so we are going in the right direction. But I think it's very important to think, of course, patients want to be parents, they want baby, they say, well, we are very happy if there are two, but if both babies are premature and have to stay for months at the neonatal intensive care unit, that's not really a good beginning in the life, and there might be sequelae as well. Next slide. So these are our results, and actually you can see that the number of cycles that we have biopsied, the percentage is not that high. And this is related that the fact I looked at it because for monogenic disease, usually we go up to 70%, but in this specific series, we had a high proportion of patients who had a low ovarian reserve. So of course, it's highly dependent on the age of the patient at the time of the treatment. The older the patient is, the lower the ovarian reserve. So the less oocyte we will get, so the less embryo we will have, and so the less blastocyst we will get and be able to biopsy. But what is interesting is that when you have a biopsy and if you have an embryo, you can see that you have per transfer a very high pregnancy rate. So this is a transfer of a blastocyst unaffected. But it's important to understand that there is a high difference between a pregnancy, which means the embryo has implanted, because we can see in the blood that the HCG, which is the hormone showing that you are pregnant, is positive, and the birth rate, and the difference being the pregnancy who's just stop evolving, which will miscarriage, or miscarriage very early, before even being seen at an ultrasound. Next slide. So to summarize, there are advantages and drawbacks of PGT and PND, and of course the major benefit of a pre-implantation genetic testing is that there is no need to terminate affected pregnancies. But the major drawbacks is that it requires assisted reproductive technique, and even if the couple is fertile, it's technically challenging, it's expensive. Well, in some countries it's very well reimbursed, but it also depends on the of each country situation. The genetic analysis can be performed before initiation of pregnancy, while of course for prenatal diagnosis during pregnancy. There are some complications, and I haven't talked about it. We can discuss about that, about some patients who would over-respond to the stimulation and having ovarian hyperstimulation syndrome. Now we can avoid it by specific stimulation procedures. Well, in some rare cases, there are bleeding or infections related to the oocyte retrieval. And of course, for the prenatal diagnosis, the risks are related to the potential termination of pregnancy. The obstetrical and neonatal risk are very limited in IVF children, but there are some differences compared to children conceived spontaneously. So in some and with frozen embryo, which is the case in PGT, they can be a bit larger for the gestational age. There is a slight increase in preeclampsia, which is hypertension during pregnancy, if you replace it with a hormonal treatment. So, well, it's not a lot, but should be aware of it. And of course, with the prenatal diagnosis, there is a very small risk of miscarriage related to the procedure. The accuracy of genetic analysis is very high, and the chance of a healthy baby delivered, well, is not that high for the PGT. So that is something you have to understand per oocyte retrieval, so per cycle started. And of course, the large difference with the pregnancy per embryo transfer is related to what I talked to you before, all the causes of failure, like if you have no oocyte retrieval, no sperm, no fertilization, no embryo, if the embryo is blocked, if you have a biopsy which is not optimal, or no answer from the geneticist. So all these issues can lead to of course, a failure. Next slide. So the take-home message is that preimplantation genetic testing is an alternative for prenatal diagnosis for couples at risk of transmitting a genetic disease who wish to have an unaffected child. Couples with a known genetic risk should be fully aware of the advantages and limitations of PGT with regard to PND. PGT precludes the need to consider terminating an affected ongoing pregnancy, and PGT involves many steps requiring multidisciplinary counseling from genetic and ART teams. And the chance of delivering a healthy baby per started cycle in PGT is restricted by the age of the woman, the response of ovarian stimulation, which is also in close relationship with the age, and the quality of the embryo. And I would like, of course, to thank you for your attention, and I will be very happy to answer your questions. And I hope it was not too long.
Was perfect. Thank you very much. I've learned a lot, I guess, also of the other. So indeed, now there is the occasion for having a debate around this topic. As I say always, you can both write the question in the chat if you feel more comfortable, or also you can unmute yourself and take the floor. I can understand those could be very intimate and delicate topics. So maybe while we see some questions arrive, may I ask, Anne, I mean, during your daily consultation with patients, which are, how can I say, the key needs you see in patients that want to go through this kind of journey of the embryonal selection or preimplantation? Do you see that there are recurrent I don't know, worries or questions or way of approaching also the topic that you could share, knowing that, of course, this is based on your experience in Belgium and...
Well, what do you mean actually? So
if when you handle these topics with the patients, I mean, if you have the chance to be in touch with the patients also, if you see some recurrences, something that always is repeated among all the people you visited on this topic?
Clearly, when I see patients, as I'm a reproductive fertility specialist, so I'm not really I'm not used to work in fetal medicine, but clearly patients coming to our IVF unit for PGT, they clearly come and say we do not want to have pregnancy termination, or we do not want to have it anymore, because some patients have undergone it sometimes more than once, and they just do not want to hear about it anymore. So they say, well, if there is another option, I would really go, even if it's long, even if it's tough sometimes, but that's one of the major motivation.
Thank you. I can see one question in the chat. Thank you for your presentation. What are the costs for the treatment and how old are the patients? Thank you.
So, well, that's a very good question, but I can only answer for Belgian patients, and I think that each country will have different rules. There are also legal restrictions to the age of the patients. So for instance, in Belgium, the reimbursement is until 42 years old, but it's the law allows a replacement of an embryo until 47 years old, and you cannot do it after. Now, even if it is very well reimbursed in Belgium, you have to, for a full cycle, meaning the pre-treatment, the genetic screening, the IVF cycle, it's about, and the freezing of the embryo, it's about, well, it's close to €1,000. But if you have no reimbursement, it's rather 8,000 euros. So it depends on the reimbursement policy of the country, of course.
Thank you. Jenna, do you want to...
Well, the age of the patients, they are, well, the majority of the patients are in their 30s, and that's usually.
Thank you very much. Jenna, do you want to... Hello.
Yeah, thank you. Hello, hi everyone. Thank you for your presentation. I'm sorry, I'm not really familiar with this, and I wanted to have further information about the background or the profile, if I can put it that way, of the people coming, because it has to be, I guess, people who know their status, that they carry the trait or that they have the disease. And do you sometimes have people who have no idea and who find out during the pregnancy and who are being sent to you?
Well, of course, I see patients. Thank you again for your questions. We have, and I think that Beatrice Gulbis was very active in promoting a screening, a general screening here in Brussels, in our hospital, in pre-conception consultations. So there are a lot of patients for whom we know the status before. We screen all patients coming for an infertility problem. So of course, if they come in our fertility clinic and if they are infertile, they will be screened for hemoglobin diseases. So we will know their status. And of course, we have patients who do not know their status, where a pregnancy is ongoing, but as soon as the patient is pregnant, we will screen. We screen everybody.
Okay.
Yeah,
And-
it depends. It depends again, if I may, it depends again from one country to the other. So what is very important is that the physician is aware of the pathologies and what they have to screen. And for example, in United Kingdom, the process is well known by the physician. They know who to screen and when. Of course, the most important thing is probably to have a family doctor, and then you are screened before you are pregnant. That's the best way. But then even if you know that you have a tray, or if you are sick, of course you do it. But if you have a tray, you have to accept the healthcare pathway too. To be sure that you go through genetic counseling, and then you are informed. So all the people all the couples or the sole mother that we see, it really depends on the way they had the opportunity to follow the healthcare pathway. So it might be very different. As Professor Delbar told you, is the fact that you may see people at the 3rd trimester of pregnancy, and sometimes you're lucky, you see them before any pregnancy.
Okay, and could you say, for your personal experiences, both of you, how often do you have patients who didn't know anything about them carrying a trait and finding out somehow with you?
I can say many of them.
Yeah, okay.
Yeah, because most often it seems very uneasy to speak about that within the family, if I may say.
Mm-hmm.
And even with the large family, and something also is the fact that if you lose your background, you are not anymore in your native country. Sometimes we've lost the information, and it's not only on the disease, but on different aspects of life. Of course, the way you eat, the way all your cultural background is sometimes up and down, and this is related to that, I think.
Okay.
And also all the couples, that there is a mixture of couple. And just to tell you, I remind a woman, and she has hemoglobin S as a trait, and she wasn't aware of it. And finally, we found that her grandmother was coming from Burkina Faso. So they lost the information just like that.
Right. Okay. Thank you very much.
Thank you. I don't know if there is anyone else that wants to take the floor or contribute to the debate. If not, I can go with the next question. So I was wondering if for those kind of patient journey, is there, like a more or less like a standard in the hospital, the psychological support for taking such a decision or going through the decision, whereas is negative or positive?
Yeah, absolutely. So, well, this is absolutely mandatory, of course, in the setting of a prenatal diagnosis where there might be a decision of, well, of course, the announced potential of a sickle or homozygous fetus, and well, to just accompany the parents to take the decision to terminate or not the pregnancy. So, of course, this is a very, very hard situation. And there is always a psychological support. We offer psychological support for all patients who would like to in IVF treatments, and this especially if there are recurrent implantation failures also, or treatment failures. And well, it's if the patient would like to, of course, we have 3 psychologists just for the fertility clinic. So there is a lot of, I think it's really very, very important.
And only in the law in Belgium, you have to wait 2 weeks before the proposal of a diagnosis. It's 2 weeks, huh? And
for termination of pregnancy.
No. When you propose a prenatal diagnosis and then you decide to perform it, I think we have to wait 1 week.
I don't think so, but I'm not sure. I must say I'm not on that really side.
Oh, yeah, I'm almost sure.
Probably you have to wait a little bit.
Yeah,
I mean, of course, but usually, you know, they already talk about it before, and then they discuss it with the gynecologist when they get the result, and then the time to take the appointment. But it has to be performed within a specific gestational age
window. A window. Yeah.
Window.
What I say is that when you have a genetic counseling, we have to we can't say, okay, well, I will see tomorrow and we will do the procedure. That's what I say.
Okay.
Maybe
For
there is a
prenatal
misunderstanding.
Yeah. Actually, I'm never involved in this specific procedure. So yes, well, it makes sense, huh, to have a few days to think of it. And there is a psychologist who is related and connected to the genetic department as well. So, a psychologist for the fetal medicine, psychologist for genetic department, and psychologist in the fertility clinic as well.
Thank you. Okay, I see one positive feedback in the chat saying very informative session. Thank you. Thank you, Agnes, for sharing this feedback. Okay, so if there is no other question, we can close the sessions saying again, thank you very much, Anne, for having shared your time and expertise with us.
Thank you for the invitation.
Thank you very much, Anna.
A pleasure, yes.
Yeah, I put her under pressure.
Because I was really sorry for this technical problem.
It always happened. I mean, it's technology. We are indirect. It always happened. So we are very used to. Don't worry.
No, don't worry. The important thing is to have you and to have all your
and to share.
Yeah, your experience. And of course there is a video, and everyone will be able also to see the video. So that's very important. Video, yes. Yeah,
it will be worldwide accessible indeed, because we put it in our YouTube channel.
On l'a
I
perdu.
lost her.
Yeah, yeah, me too.
Okay.
Sorry, I think I was lost. So I was saying
You were fixed. You were fixed.
okay, so I was saying thank you very much to all of you, and
Okay.
see you on
At the
the next
ASCAT.
see you at the ASCAT for people that are coming. Yeah, see you in London in 2 days.
Yeah.
Okay.
Thank you
Bye-bye.
very
Bye-bye. Bye-bye.
Bye
Have a
bye.
nice evening, everybody. Bye.
Yeah, you too. Bye.
You too. Thank you.